Welcome. Thank you for joining us today. You are here at Building Equity in Rehabilitation, a panel discussion to facilitate inclusion. This year's AACVPR keynote panel is going to present a conversation around disparities in healthcare and some ideas for equity. We've invited some panelists here today to share some insights and their thoughts on several video vignettes I'm going to present to you today of both patients and some provider stories. Hopefully, the session will serve to generate some ideas and strategies that might resonate with you and to perhaps inspire you to implement some similar strategies in your own programs. I wanted to open also with a quote from Lisa Cooper. She wrote a book called "Why Are Health Disparities Everyone's Problem?" And her quote is, "Equality aims to promote fairness, but it can only work if everyone starts from the same place and needs the same things. Equity means that everyone is given what they need to be successful, even if those opportunities come in different forms and are used in different ways." So join me in welcoming today our panelists. I'm going to go around and ask them to introduce themselves. So first, I would like to start with Dr. Columbus Batiste.
All right, good morning. Thank you for inviting me. It's a pleasure to be here. As Amy mentioned, my name is Columbus Batiste. I'm an interventional cardiologist by training. I work within Southern California Kaiser Permanente medical system. And what we do, my role there is I'm the regional medical director for the home-based cardiac rehab, which delivers cardiac rehabilitation across all 13 medical centers. I'm also chair of the Regional Cardiac Quality Committee. And so it's a pleasure to be here with you today.
Thank you. Also introducing Yvette Gertis.
Hi, thanks for having me. I'm Yvette Gertis. I work for UC Health. I have 2 cardiac rehab programs. Actually, it's cardiac rehab, pulmonary, vascular, and a cancer exercise wellness program. And I'm just happy to share our stories and see how we can grow and develop. Thanks for having me.
And finally, Salim Street.
Good morning, everyone. My name is Salim Street. I am the Director of Clinical Programs at Ascension Seton for cardiac and pulmonary rehab in the Austin, Texas area. I'm very happy to be here and happy to be on this panel.
Thank you all for being here. I want to start off with our first video presentation. This is Dr. Amber Clark. She works with me at UAB in Alabama, Birmingham. She is a PM&R physiatrist in physical medicine and rehabilitation, and I'm going to share her story.
Hello, everyone. I am Dr. Amber Clark Brown, an assistant professor in the Department of Physical Medicine and Rehabilitation at the University of Alabama at Birmingham, or UAB. I've been practicing since July of 2020, so I'm no longer in the infant stage of my attendinghood. I'm now proudly reporting that I'm a toddler. But with that said, I've been asked to talk about my experience with cardiac rehabilitation and pulmonary rehabilitation. Now, I'm blessed, and I realize that because I am in the field of rehab medicine, I do have a little bit more knowledge about cardiac rehab and pulmonary rehab. However, it's been clear and has been made very evident that there is a dearth of education around these very valuable resources for our patients. I can think of 3 instances even within this past year that I've either referred patients to cardiac rehab. I do consults on the acute care side of the hospital, and my consults are in the stroke population. So as we know, if you have a vascular disease, it doesn't just affect one vessel. Typically, our patients that have strokes already have cardiovascular disease, or they may have comorbid pulmonary diseases as well. They're increased risk of COPD, etc. So these patients, one in particular that I'm thinking about, had the diagnosis of COPD, and she'd had a stroke. At that particular time when I was evaluating her for inpatient rehab, she didn't meet inpatient rehab criteria, but I knew that she would be a perfect candidate for cardiac rehabilitation in the outpatient setting. It would improve her function. It would improve her quality of life, and those are the things that we look at in PM&R. However, there was an issue with insurance, and if I'm not talking to anyone else in the room, I know I'm talking to someone, and I say that tongue in cheek. You wouldn't be here and listening to this panel if you didn't realize that we do have an issue with accessibility in this nation, and to very, very valuable resources that patients need. When we talk about health equity, allowing people the space to really fulfill and meet the highest quality of health that they can, we run into a lot of barriers there. So, in thinking about this a little bit more, and the experiences that I've had really advocating for patients, just by simply giving them information that this resource is available to them, I look to the future and how we can change the healthcare system, how we can identify these gaps in the healthcare system that can really propel our patients forward. And not just our patients, particularly for me, our patients in our most marginalized communities, those in the disability community, those that are in the minority communities. And when you have all of these different intersections, it just adds to more and more barriers that our patients can and often do face. One of the things I think that should be a point of conversation is, where do we start? I think it is very important, and I commend the work that's already going on with cardiac rehabilitation and even just this panel, starting the conversation. I truly believe that there is a lot of value in speaking with people, their experiences. How did they learn about cardiac rehab? How did they learn about pulmonary rehab? Were they insured at the time they were referred, or did they have to wait to be insured? Did they have to go through a particular process? And how long was that waiting process? After that, again, talking to them, we can identify the gaps to help inform policy change. I know that I'm in a very blessed position to be a physician, and I am honored to have colleagues such as yourself working in different arenas that get it. We get that there are inequities in this country. We get that it seems to be the same story over and over and over again. But what you guys are doing here, what this represents is progress, and that we don't just see it, we're taking the steps to address it so that we and our future generations can have a more equitable society where everyone can achieve their divine potentials and truly rise to their own occasions and become the best that they can be. Thank you.
Okay.
Yeah, that was powerful. That was powerful. There was a lot that was packaged inside those few words there in that moment. And what I can reflect on, to me, one thing that jumps out is the fact that she said, "Where do we start? Where do we start?" And I believe that where we start is we start with us on the inside. As an interventional cardiologist, when I'm doing a case and a patient isn't doing well, I don't look to what the nurse did or what the tech did, but I look first, what did or didn't I do? And I noticed that with all of my colleagues, to figure out, how can I solve this issue? Is it something that went awry in the procedure? And so I think the same thing has to happen when we're looking at this issue of inequities and disparities. And there is something out there that's called, and Amy, you alluded to it, implicit bias, right? And so we know that even the most fair-minded individual can discriminate. We know that this thing called implicit bias is subconscious. And it's not only a negative connotation, it's also a positive connotation. So, admittedly myself, when I have a colleague who's from England, I immediately assume that they are smarter because of their language. I believe that all of a sudden when I hear them talk in the accent, that they're smarter. That's a level of implicit bias on the positive side. But we know there's negative aspects to implicit bias, and that's been demonstrated consistently inside the medical literature. One thing I want to outline to folks as we think about this, because we say, well, we treat everyone the same when they come in. If you have a diagnosis, I'm treating the diagnosis and we go from there. But when we look at the continuum of care, even as it relates to acute cardiac events, imagine someone going into emergency room with chest pain. Well, studies have shown that minorities going into emergency room for chest pain are less likely to be admitted. But once they are admitted to the hospital, what studies have been shown is they're less likely to receive the invasive procedures like cardiac cath. But for those who do go through cardiac cath, those with critical lesions are less likely to receive life-saving therapies of intervention with drug-eluting stents or with open heart surgery. And finally, as full circle back to us, what studies have shown is that women and minorities are less likely, as we all know, to receive referrals for cardiac rehabilitation. And so this continuum of care is interlaced with this thing called implicit bias.
So what do you think is going on in that bias, in that moment that a physician or a provider is not forwarding one of these patients on to cardiac or pulmonary rehab?
Yeah, I think that there's assumptions that are made, right? And so these assumptions that are being made, these judgments that are being made before a person based upon how a person appears or their financial strata or whatever it may be, their gender or their sexual orientation, the presumption of whether or not they are going to be willing, if they're compliant, if they'll want to do it. And these judgments, these subconscious judgments, lend themselves to the worst case scenario of us as providers not applying evidence-based recommendations.
So just piggybacking off of what Dr. Patisse just said, it is about the implicit bias, and it is about starting with us. We have to recognize and understand what an implicit bias is and look in that mirror and look at us and say, I try to be really neutral. I don't think I have any implicit bias. I don't think I'm judging the book by its cover. I'm actually getting to know it. But we really need to look at ourselves and, what am I subconsciously, what am I holding on to? What am I judging before the person gets here? For me, it was very eye-opening. We did an implicit bias education at my facility, at my health system, and I took a test. And it was, I took the one on obesity. I don't have an issue with obesity. At least I thought I didn't. That opened my eyes a lot. So it is about starting with us, educating us, and then looking forward and really taking a hard look at yourself and looking at how you're treating not the disease, but how you're treating that patient, and really being patient focused.
Salim, do you have other kind of thoughts on who's coming into your program or some of the barriers you're seeing in referrals?
Yeah, I think both Dr. Patisse and Yvette said it very eloquently about looking at your subconscious, making sure you have those conversations with the provider when you get the referral, or you may not even get the referral, to say, hey, I need you to understand that don't screen the referrals because you have maybe some bias that the patient that patient won't participate because they're overweight or they're smoking or they work and they don't have any. Allow our programs to work with those patients and figure out a way to reach them at a level that allows for everyone to be included. So in our program, I speak to the providers consistently all the time. If there is a missed referral, I talk to them and kind of try to figure out why that referral was not made. So I think it's important to have ongoing dialogue from your staff with the providers to make sure that they understand that it's important that everyone should be included in referral to cardiac and pulmonary rehab.
Are there other strategies that seem to be making a difference in improving these referral rates?
Well, I mean, what I can tell you is, the literature is fairly clear on it. There's a lot of system-wide structures that have been implemented that improve the referral. So you can have an automated approach in which individuals are just automatically referred over based on their discharging diagnoses. But I'll tell you, the most effective way to impact referrals, and even going a step beyond referrals, but are actually enrollments, is communication. Communication is indeed the key. And so that communication begins with communicating to providers the importance of cardiac rehabilitation, right? So because we speak about implicit bias and it sounds like, oh man, that's a catchphrase nowadays. And it seems like that doesn't affect me. So let's flip the paradigm and let's call it beliefs, our beliefs. If I believe in medications, I'm going to prescribe medications. If I believe you're not going to take the medications, I won't give you the medications. And so we have to first impact people and move them away from this false narrative that cardiac rehab is not important. The second thing we have to do is we have to move people towards away from this electronic. So we're in this world of telemedicine, which we'll never leave, and it's extremely beneficial. We're in this world of electronic medical records, but what that does is it creates a barrier between us and our patients. That barrier is a communication barrier that then begins to have a domino effect and can lead itself to not connecting and for patients not to understand the importance of what we're trying to convey.
Well, that's a wonderful segue into patient stories now. So let me go ahead and introduce you to Cheryl. She has some experience that she wanted to tell you about her understanding of how communication affects her healthcare.
Hi, my name is Cheryl Williams, and I would like to share with you my experience at cardio rehab. Well, when cardio rehab was introduced to me, or my doctor was saying, well, listen, for your situation, I'm going to send you to cardio rehab. And I was like, well, what is that? And she explained that how they monitor your heart and how applying these exercising and eating a better diet, could help me and my situation. And so I said, okay. I was very scared and very nervous because you said they're going to hook me up and they're going to monitor me while I exercise. So I'm like, oh my God. So I can just imagine all these cords and all this going everywhere. But when I got there, everyone was so nice and they were so gentle with me because I was looking kind of worried there. But once they hooked me up and everything was wireless. So hello, that was a fear gone. And then I was just exercising. And it felt like it was just so smooth and so just right. Exercise, I'm done. I go home. So after a couple of weeks, well, maybe a month or so, I was like, well, is this really helping me? What's the difference? I just feel like I'm just coming, I'm exercising. And so they explained to me how it was strengthening my heart and how, when you first came in, you was only exercising like 16 minutes. And then it got higher and higher and higher, the time that I can go. So I was like, oh, okay, well, that's good. And so that was good. And everybody who came in contact with me at the cardio rehab place that I go to were very helpful, very encouraging, and very helpful to me. So I thank them all for that. I thank my doctor for really, talking to me and saying, this is what I feel is good for you. I want you to do this, and I thank myself for listening because it has helped me. It has helped me. And I did listen to her. And I think that when you have a great communication going on with your doctors and feeling like my questions may seem a little weird or kooky, ask them anyway. A patient should ask them anyway, and a doctor should, which my doctors do, just answer me no matter what I have coming at them. Answer me. So that communication is very important to have with your doctors. I have not always had a great communication with doctors. There was a time when it was several years ago when I was in this situation where my doctor he wrote out this prescription for me. Well, actually, he was telling me that, sometimes it takes two blood pressure pills to bring your blood pressure down. I had a problem with blood pressure. And so I was on one pill. He wrote out a prescription for another. And he said, you should just take this pill, and it didn't work out. There was no communication. That pill didn't make me feel good at all. And it caused a whole another issue. And he told me he never told me to take that pill. So I kind of lost confidence in him and all doctors. But I'm very glad to say that, now I'm in a better place, and I'm listening to my doctors, and they are listening to me. Communication is very important. And so I just want to say thank you to Cardio Rehab for communicating with me and me communicating with you. And it was just awesome. And if anybody needs to go, I'm going to say I'm a witness. You go. It makes a difference in your life.
What do we think?
What really spoke to me was the last part of Cheryl's commentary about she lost trust in her provider because the communication wasn't there. Over the years, I have really tried to focus on effective listening and communication, and it's not about what my goal is for the patient. It's not about what my program's outcome goals are. It is 100% about the patient. And if you don't have that communication, or you're not communicating on that level and hearing the patient and what they need, you can't deliver the best care. Some of the patients really need to know, hey, you're going 2 minutes longer on that treadmill from where you started. This is why we do it. And we can't assume that everybody understands what we're doing in here. What is cardiac and pulmonary and vascular rehab? Oh, it's just exercise. Is it really? It's more than exercise. It is education. It is behavioral change. It is coaching. It is setting that person up for success and putting them on their road. And we're just there. Like, if you take a detour, let's know why we're taking a detour. Let me coach you up. So building that trusting relationship to let them open up to you, to really help them succeed, listening to them and communicating on levels that really speak to them. It's not just about you need to exercise because you had a heart problem, or if you exercise, your lungs are going to feel better, and I'm going to teach you how to diaphragmatic breathe. And those things, it is more all encompassing. So it's teaching the providers, the worldwide tour, as I like to call it, of what we actually do and how to translate that to their patient. I've actually gone and started having my staff go down to certain clinics to train and educate the nurses or the MAs and the physicians about what we look for. This will be a good candidate. Talk to them. If you don't want to talk to them or they're still on the fence, call us. We'll talk to them. Put the referral in anyway. Let us talk to them. Let us have that communication. Let us build that relationship from the start. That's kind of what I took from Cheryl. She had a great experience once she was there, but she didn't understand the reason why she needed to go. And it's all about the why. Those are happy to discuss.
Other
That's
thoughts?
good stuff. Absolutely. When I look at this, and so I'll be honest, Amy and Yvette, I take it personal when she kind of mentioned about the disconnect with physicians and her distrust in physicians. And it brought me back to something, Yvette, you said during the last segment. You spoke about taking a test and you didn't realize that you might have had a bias towards obese patients. And there were studies that were actually done looking at physicians and providers in this thing called the implicit association test. And what they found inside this whole paradigm here, this research, is that individuals were biased, and this bias led to their preference, led to their recommendations. And so what they found is that when they had bias or a preference for one group but not another, they tend to spend less time. They tended to spend less time in the office visits. They tended to overtalk them. They tended to give them less time to speak. They provide less eye contact and smile less. And so where are the results of that? The result of this is that there is a breach in the trust between the providers. Like the young lady spoke about, she started a medication and felt a breach in that trust when there was a disconnect there. She was uncertain when the recommendations were given about the rehab, about the the utility of it until communication trust was reestablished. And so there's so much power there when we look once again internally at ourselves, because our biases will impact, oftentimes they mirror what the response is on the other end from patients.
And so what about things like advocacy interventions? So ambassador programs or community healthcare workers or education, where do you see some of those opportunities lie?
I think that's extremely important. And so I definitely don't want to jump and take over the conversation. So Celine, jump in here and then I'll pause for a second. But I think that obviously when you're working in the community, whether or not it's a church group or if it's a certain type of organization, that an individual already feels a level of value. They feel as if this group is trusted. Their church, their mosque, their synagogue, whatever it may be, that it's valued and it's trustworthy. Collaboration with healthcare providers with those institutions further strengthens that bond, right? And it brings us down to a level where we're now able to communicate on similarities and like terms with them. So I think it's extremely important.
One of the things that I try to instill in our program and with our staff as we try to breach this subject is people don't care how much you know until they know how much you care. So once you establish that caring part of it, and what that looks like may be very different for different programs, but what we try to do is a patient comes to us, they're scared, they don't know what's going on. We start giving them education at the level that they can understand. And then we also follow up with the providers with notes, with different, if they had a nutrition class, we let them know. So when they have that next appointment, our program, we try to make sure that provider says, hey, the cardiac rehab sent over what you're doing in the program right now. And that builds that trust in the community. Oh, they're talking to the cardiologist about my care and my progress. And so as that trust develops, you get more compliance. And when you get more compliance, that means that they complete the program and they get the entire benefits of the program and not just the exercise. They get to understand, they meet with maybe your chaplain, or they're able to meet with the nutritionist, and from the psychosocial standpoint are able to build them up where they may be weak in the situation and also improve their health literacy. So I think that is where I think it's important that all programs try to get that part of their program.
I would also say that feedback loop back to your referring provider is a helpful piece of information, because one of the things that the literature does show is there is absolutely a disparity in referrals, but not always a disparity in attending and completion rates. So if you can get into the program, you can stay in the program. The real barrier seems to be much more focused on the front end with referrals and getting into the actual centers and programs. I also want to move you now to another patient story. This is now a pair of patients that I want to introduce you to. This is Jose and Pedro.
He absorbido todo lo que ellos me han explicado, de mi corazón, de mis riñones.
I have opened up my mind and I have absorbed everything that you guys have told me about my heart.
Was there anything that made it hard for you to get here, like transportation or the amount of time you had to come? Were there any things like that made it harder for you, even though you wanted to come, but made it harder for you to participate?
¿Hubo algo que fue difícil para usted participar, como transporte, el tiempo, algo que lo hizo difícil para que usted participe?
Más que todo el transporte, porque vivo en winter.
More than anything, transport, because I live in winter.
Oh, okay. All
Yeah.
right. Yeah, that's quite a distance from here, isn't it?
Sí, es una buena distancia de aquí, ¿no? Sí. Yes.
So, just because there's staff that speaks Spanish, that's made it easier for you to participate in the program. Is that
Porque
right?
han habido personas que trabajan aquí y hablan español, ¿le ha facilitado más el programa?
Mucho.
Very much.
What types of things do you think you've been able to participate in that easily that you might have had difficulty participating in if there had not been a Spanish-speaking person to help you?
¿En qué cosas se le ha facilitado el programa habiendo estas personas que le han ayudado en español a que si no hubieran estado ellas?
Me hubiera dado mucho trabajo para llegar hasta donde estoy ahorita, con todas las participaciones que ellos me han ayudado. Si no hubiera esas personas, yo no estaría en el programa este.
It would have made it a lot more difficult for me to progress the way I have, and with these people that have helped me, I've been able to progress.
Yeah.
So, how did you decide to come to the program? How did you overcome that fear or those thoughts about not being able to understand and participate fully in the program?
¿Y cómo decidió al fin venir al programa? ¿Cómo pudo sobrepasar ese miedo que sentía del idioma?
Porque llamé y pregunté si había alguien que hablara español ahí, y sí, me pude comunicarme con Araceli y José, pues que ellos hablan español, ya pues pueden ayudarme a mí.
Yes, I called and I asked if there was anyone that can help me with the Spanish, and it was there was Jose there, and
Salió bien, te está saliendo pues bien.
that was the main thing that was preventing me from attending the program, but everything is good. Everything came out good.
Tell me a little bit more about how having somebody who speaks Spanish in the program has been helpful for you. What types of things have you been able to do because of that?
Dígame más qué lo ha ayudado el hecho de que hubiera una persona aquí que habla español. ¿En qué más lo ha ayudado eso?
Pues en muchos aspectos, como ellos son muy amables, pues cualquier pregunta que yo tengo, pues ellos me ayudan a quedarme yo conforme en lo que ellos me contestan, pues.
Yeah. They're very good, and any question that I had, they have been able to answer them.
Initially, you were thinking about not coming because you were fearful about the language and not understanding. Is that right?
Entonces quiero clarificar, al principio tenía miedo por el idioma y que no iba a comprender, ¿correcto?
Sí, exactamente. Yo pensé que no iba a poder hacerlo y dije, pues no voy a recuperarme igual, pues más pronto que si lo hago, no lo hago el programa.
Yes,
pero sí,
exactly.
Estoy muy contento con estarlo haciendo.
Yeah, I didn't think I was going to be able to even progress because of the language barrier, but I'm very happy.
Okay, Salim, now.
Yeah, so both Jose and Pedro make very excellent points about building the trust with the language barrier. So I think you have to represent the community that you are in. So I happen to live down in the Austin, Texas area, and Spanish-speaking patients are very prevalent in our community. So I think it's very important that your staff represent the community and your program represents the community that you serve. So what I have noticed is we have diversified our staff. And when we did that, our Spanish-speaking population became more compliant. We actually were able to raise our compliance level among that population like by 70% or more. What we were finding is as they were coming and they were able to communicate with our staff, they also saw other patients there that were like them in terms of Spanish speaking and were able to build a sense of camaraderie with the patients that were also in the program at the same time. There was something else mentioned also that is transportation. I encourage in our organization, we were able to use rideshare, Uber and Lyft, to get our patients to our program. That may look different in the community that you guys are in, but when we started using those services and our administration approved to do that, we saw compliance in the transportation issues go way down, and we were able to get those patients to come to our program as well. You have to remember, our patients are with us for 3 months, so they or more. So as they come and they get to participate in the program, it's really a sense of community. So I highly encourage, and I think it's very important that you diversify your staffing. You make sure you also are able to provide some type of transportation to remove that barrier for those patients to participate in the program. And speak with your leadership about getting on board with providing that as well.
Yeah, I'll jump in here. I agree, and I'm not sure what the other members of the panel are going to feel about this. I don't even know that I actually discussed this before. But one of the things. Sorry, Amy, I'm gonna throw a little wrench inside of here like this. But one of the things is that from an administration standpoint, there may be challenges in hiring up, and some of you out there listening may face this in terms of hiring diverse staff if you're already have your FTEs established. But one thing that we've done within our program is we are staunch utilizers of the virtual interpreters. And so I have numerous cases in which individuals, I have the monitor on for an hour as we're communicating back and forth. And I can't tell you the one that several stories just stick out. And it gives me a little warm, fuzzy feeling inside with the patients being so appreciative of being able to communicate. And that was the one thing they said to me. One patient actually said, that's my greatest fear, is not being able to communicate, right? And so for someone not being able to understand them. So don't be limited by a lack of resources in terms of bodies. There are other avenues, and we live in a day and age in which we can still deliver care in a timely fashion, in appropriate fashion, and at the level and the impact for the patients.
I agree wholeheartedly. We use the video interpreters. We actually have one interpreter that comes on site to do sign language because it worked out better for the patient. And I have a staff member that's kind of following and learning a couple of the signs. So at least if the interpreter's not there, she can get him started on the equipment. We've diversified our staff, male, female, modalities, different ethnicities, as well as races. So, the only thing we don't have, I would say, is an older population of staff. We're a little bit younger on our end, but the guys don't seem to mind that. The patients don't seem to mind that. They're okay with it. A lot of things we also did for our staff was I'm starting to do lunch and learn, so they know how to activate the financial aid system to help patients pay for this. And they've learned how to do the transportation and can help patients with the transportation. I would love to have a better conversation about using Uber and Lyft for our patients, as well as, we've started doing a bunch of different, just more education for our staff to let them know what patients need and don't need and how can we help them, and following up with the patients if they haven't been for 2 days, what's going on, what can I do to help you?
Wonderful. I wanted to ask the panel to just address a little bit more this idea of bringing in the next generation of staff and providers, and how do we diversify the workforce? What are some ideas that you have about, bringing in people in fellowship programs or training programs or internship programs? I know for, Yvette and Salim, exercise physiology, what are the opportunities for people to get introduced to the field?
So I have been reaching out to our local colleges, University of Cincinnati, it's our biggest affiliate, and we're talking to them in one of their allied health professions class that talks about the different allied health professions that they can go into and really kind of bolstering up that cardiac rehab. As the past president for our affiliate, the Ohio affiliate group, we've been trying to implement an emerging professional program to get more students involved, but also if they have that kind of, I'm brand new, what can we offer those people to get them involved or more involved while they're searching for jobs or when they're just starting out in the workforce, of how do we get started from the professional end? That's what I've been looking for exercise physiologists. from the fellows end, as they're learning about cardiology and trying to get more specific and get that extra training, I'm trying to meet up with them and figuring out how we can, they already have a lot of duties and fellowship, but figuring how can we get them into the program maybe for 1 week to see what we're doing so that they can speak better to the program.
I agree with Yvette. I think I've done similar things in terms of going to Texas State University is the university in my area. And I've gone and presented in some of their clinical populations classes, exercise physiology classes, and told them about the field of cardiac rehab and got a great interest that way. We have a strong internship program with that university as well that participates in all of our programs at my organization. I also think it's important pastoral care. So we have a residency program for pastoral care that we've engaged with where they send their residents to our program, and they would come once or twice a week and come and speak to our patients and try to understand where they are from a psychosocial standpoint. And that has been very helpful. The feedback from the patients I've gotten from that and my staff from that has been so positive that we're trying to look to maybe get a part-time FTE to get spiritual care and pastoral care, but to participate and be a part of our program. We found that hugely successful.
No, that's good. You know what? In some of the community nonprofits that I participate in, one of the things that they've done is they've done a sort of reach back, and they start actually at the high school level to really try and increase the exposure of the youth of tomorrow, our future for tomorrow, as it relates to all the different specialties. And so that's been actually fairly impactful. So whether or not cardiac rehab, teaching, whatever it may be outside the typical proscript. The other thing that's been done inside of many of the nonprofit groups I've associated with is they've gone back to communities, whether or not it's historically Black college and university or the groups, to try and give them exposure that, hey, there are fields out here within medicine beyond a physician or beyond a nurse or beyond a professional on that level, and a different level type of professional where you can be impactful. You can impact your community, patients, and live a great life too as well. And so there's many strategies and all beneficial.
All good ideas. Wonderful. All right, let me introduce you to our last patient. This is Tawana. She is from our program here in Birmingham, Alabama. So pleased to share her with you today.
Hi, my name is Tawana Salters. I am currently 32 years old. I live here. I'm a resident of Birmingham, Alabama. I am a previous patient of cardiac rehab at University of Alabama at Birmingham. I did cardiac rehab at UAB, and I was there for 6 months. I did it from 2020 of August to January of 2021. I would say it was amazing. The staff was great, very just uplifting and just great people. And even though it was their job to help you get better, but they genuinely wanted to see you win and succeed. You know, they were your biggest cheerleaders, but at the same time, you felt safe there because you have a medical staff. I mean, I had RNs on board. You had exercise psychologists, the whole 9 yards. And it was very comfortable. And keep in mind, I did rehab in the middle of COVID, the beginning of COVID. So, again, that was another thing that was kind of pressing. Like, oh, my God, I'm going to be safe. But once I got there and I met the team and we did these processes, steps and everything, it was great. So some things for me about what I experienced was that, again, it was just, I had people in the same situation as me that were going through the same thing, so we could relate. We have shared our different stories. A couple things that I would change about cardiac rehab, my experience was, I would say, when I spoke to some of the people that were actually in my class, my sessions with me, some of them had proper transportation. I think that would be good if they would actually have like some type of transportation for people that are not able to get there, like a little bus or something, or add that in the package if you are going to be able to do cardiac rehab. Also, I would like to see different ethnicities, to be honest with you. I really would, and different ethnicities in different age groups, different religious people or their religious backgrounds. I would like to see that as well. And also, too, I noticed in all of my sessions, I did not see anybody, I didn't see my peers. I was always the youngest one, which was perfectly fine, but I was always the one, like, they would look like, whoa, what are you in here for, And I would slightly tell my story, and they would be shockingly and pleasantly surprised. But that's another thing. I would like to see more of people of my age or within your age group. Again, I think also, too, I would like to see a cardiologist that would just come in one of the sessions just to, tiptoe around to see, how things are going. And they don't even have to tell us that he's a cardiologist. Just come in and peek and see how the program is doing. I think that would be great. I would like to see more women, not just of color, but just more women in general. But I think that's, to me, about it for the program. Other than it was amazing. A few little tweaks that I would recommend. Also, too, one last thing, a Saturday session possibly. I was grateful to have an employer that understood my work schedule and understood that, hey, this is very important for me. I need to heal, and they were all on board. I don't know if other people had the same advantages as me, but I think that played into some people not being able to attend. And I can say to this day that I'm a testament that, hey, no matter your age group, your ethnicity, life happens. And me being a healthy person before, very active, still active, it could happen to you. And it's just really nice to have that option of cardiac rehab, not just in your back pocket, but just knowing that there's a program that understands your condition and they really want to help you have a healthier and better life. So again, I just want to say, for anyone that is considering cardiac rehab, it's a no-brainer. I wouldn't underestimate, second guess or anything. Just say yes, because the results was great. But at the end of the day, though, when you do complete that program, you have your confidence and everything. You do not quit. Do not stop. No matter what goes down or anything like that, you just keep on going. No matter if you fall and just get trampled over, just know that you have the tools which you need, because they do help you. These are things that you take with you after you finish the program. So again, I strongly recommend it. This is a wonderful program, and I recommend it to anybody, any age. But no matter what, quitting is not an option. Just know that you have people that genuinely care about it. They don't even have to know you. They still want to see you do well. Just trust the process and show up, be positive and happy, even when you're tired. Because I will say that team that I had, I met the whole team. They were amazing. And just know that, hey, you're not in this alone. Hey, you got people to have your back. So best of luck. And again, my name is Tawana Salters. currently 32 years old, and I hope this helps you out in any type of way. Have a good one. Bye.
Just queuing Tawana up. She had a lot of great things to say about rehab that has been expressed by everybody, even our physician earlier. But it comes back to full circle of, how do we get more people in of the diverse population? How do we make it more equal services and reach everybody else? We're going back to that loop of implicit bias. Our physicians assuming, let's say for me, 45-year-old female, runs half marathons. Oh, well, she already is fit. She already runs. I'm not fit, by the way, but she already runs. She's already working out. She does this for a living. She doesn't need this, but you do. You need to get some more tools. You need to learn how to redefine your new normal after this chronic event, whether it be your pulmonary, whether it be your cardiac or your vascular with your pad. You have to learn how to redefine your normal, and a little bit of redefining yourself and what your life looks at. As far as programmatically we can look to see what we can do better and what we can offer to make it a little bit easier on our patients. I, for one, have started a hybrid virtual program for our patients, which I think is going to be huge. And I hope it continues past our emergency COVID regulations that we currently have. It has made life for some of our patients easier because they can shut their door in their office and go meet with us for half an hour on their lunch break, right? So they're not leaving work. It's not an 45-minute commute, hour workout, 45-minute commute. It makes it easier. It's easier on the mom if she can do it from her house. Maybe her kids are in the background doing it with you. Guess what? You just did lifestyle family wellness. You hit the whole spectrum. Transportation, it's one of the biggest things. Females, African Americans, we all know this, but it's what can we do to make it better? What tools do we have? What tools, as managers, directors, providers, can we give our clinicians that are on the front lines to help them be successful, to coach these people through their journey?
Wow. Just listening to you, Yvette, it brings back memories of a patient of mine, and this is literally probably about 8 years ago, who was a very pleasant lady, hard worker, young family, and struggled getting into her appointments to see me. Had a heart attack, sent her to rehab. She would always no-show. And I felt I was a good communicator, a good listener, but she didn't. And I remember years later, she had another heart attack, and then she ended up passing away. And I remember in this moment, I was just I had this moment of fragility, and I was tearful that how did I fail this lady? Yeah, sure, I prescribed her the meds. Yeah, sure, she went for a cath. I recommended rehab, but she wasn't able to because she had a job that prevented her from making her appointments. She had a job that prevented her from going to rehab. And I'll be honest, that was really the springboard for my personal journey as a clinician to say we need to develop a home-based rehab program. And so as a result of that, being able to deliver care where a patient needs it, where a patient wants it, and the appropriate care at the appropriate time. And so I think all these things are so important that as we look beyond ourselves and what we feel is important, that as the literature backs us up and as we obtain more and more information, we have to be willing to change, to deliver care the way it's intended for the individuals, the way they need it. And so very powerful in terms of the words that you spoke, in terms of the words that the young lady spoke on the video. And it brings back memories of my own personal patient.
It's clinicians letting themselves be vulnerable to the fact that they're not always going to be able to give the patient what they need, but being open to what did I learn from this patient and how can I apply that to the next patient?
Correct.
I started off in pediatric cardiac rehab. So totally different dynamic when you look at transportation. I'm just not looking at the kid. I'm looking at the parent. How are they going to get them there? And it was a huge dynamic for me. In addition to, I had one patient that would talk to me, but not talk to her doctor. And I had to have that conversation with the physician. And he goes, why will she talk to you? And I said, because of the color of my skin. And you are a well-dressed Caucasian male with a lot of education. I said, and that is intimidating to her. So that was a hard conversation to me, but it was a great learning and team experience on how we could change that dynamic. And actually, in story, the physician started opening up to her a little bit more and changing his approach, and they actually had a better connection throughout her providership. So.
Wow. That I'm jumping one last time. Sorry, Celine, because that right there, I don't need to go after you, Yvette, because you trigger all these thoughts inside of me. And so there was another one that from research that kind of looked at how can we alter this implicit bias. And you kind of brought it up, really. They give several different things in this research, and they talk about common identity formation, right? Trying to connect with people and see what do we have that's similar in common. Do I love the Lakers? Do I love the Cowboys? Where are my favorite teams? Who's my favorite singer? And you form this bond of connectivity, taking the perspective of saying, what was life like before? Oh, I used to cook with my mom. I used to cook with my mom. Or, hey, I used to play with my dad. I used to play with my dad. And so now you have this perspective taking, right? This opportunity that's there. And so as a provider, you begin to do this and you consider the opposite. let me challenge my thoughts. Let me challenge my notions of bias about this person that they're not going to do it because, right? And as I begin to challenge this in my own mind and try and look for supporting against that, all of a sudden it opens my mind that this is a person just like myself. And so there's a lot of power there. Sorry, Celine, for cutting you off, jumping in there. But man, I tell you.
Oh, that's great, Dr. Batiste. I mean, you hit the nail on the head. It's powerful to find what connects us instead of what divides us. So I think we have to find the commonality of that. I think what you said is right on point. I think when you look at the future and you look at what we're starting to see in our programs, I think some center-based and home-based is definitely going to be the future to try to reach the patients where they are. The other thing Tawana mentioned was peer support. I think in our programs, we've tried to provide that in our pulmonary rehab, we have a group called Easy Breathers. And what we do is we monthly bring in a speaker. COVID has kind of made this a virtual type of event, but we bring in a speaker and then the patients can connect with what they're doing. And I think COVID is going to also impact the age of the patients that we're going to be seeing in pulmonary rehab as well. And we are already seeing that to where these young people who have post-COVID diagnosis, who are on oxygen tanks, they need somebody to support them that looks like them in terms of age and help them understand that they're in this together and they'll be able to get through this and get better. So I think the future is very important to be inclusive. And one thing I will say is also for the underinsured patients is the copays and the different things that you can do as an organization. Our organization has chosen to put people on payment plans, so it's not so intimidating right up front, the cost of the program. And so the patients are like, okay, I can do that. Pay, our organization, I feel blessed, is very fortunate that they let them stretch it out. And so removing the barriers to participation in the program from a financial standpoint, along with peer support.
I know we're probably getting ready to close. I just had a random thought. What you take away from this is think about like the 3 C's: challenge yourself, communicate, and connect. That seems to be the theme that has happened with this conversation and listening to our stories. The staff need to challenge themselves. The patients are already challenged themselves by coming to us, right? We need to communicate with them. They need to communicate with us. And then we need to have that connectivity to keep on bringing them in and have them tell their story to someone else to bring that person in. So it's challenge, communicate, connect.
And this conversation really does generate so many wonderful insights and ideas. And I think that this DEI office that many of our organizations have is a bit of a wasted acronym, because if you move around inclusion, diversity, and equity, and you tack an A at the end, you get an idea. And that A is access for our patients, but also accessibility for us, that this material feels doable, that these are great ideas that maybe I could do or you could do or somebody else might be inspired. And also an A for accountability, that it is time for this to change. And we all have some responsibility in making this change happen. And these ideas are things that we can continue conversations around. And every single one of us can be inspired to say, I think I can do that. I can be a champion for that within my organization. And I want to take this idea to the next level. And once you start down this path of a good idea, there's just more of them. They need to be nurtured and fostered and shared and grown. And hopefully this panel may inspire those of you who are attending today to take up this mantle and this cause, and to keep doing this good work that we are already doing, but to share it with more people and to get that word out. So I guess I want to just thank our panelists today. Thank you so much for your time and attention, for the many meetings that we have had over the last couple of months to get this panel into shape. This conversation will continue. Also, thanks to our video panelist contributors. So for our patients and for our provider who joined us, we are paying our patients for their time and their effort. So it's important to acknowledge their contributions as well. And that this conversation will continue. On behalf of AACVPR, as the president-elect coming in, it will be part of my mission and purpose to make sure these conversations continue, not just at the board level, but also through our committees and leaders and task forces to incorporate components of diversity and equity in everything we do as an organization. So thank you all. Hopefully you will enjoy our conference. We have lots of content for you, lots of continuing education credits. Enjoy this conference, and thank you all for participating and being members of AACVPR.